All right, get ready to dive deep. Today it's cholinesterase inhibitors and anticholinergics. These drugs are kind of a big deal in anesthesiology, not just for exams, but like actually keeping patients safe in the OR.
Oh, yeah. They're essential.
And honestly, prepping for this episode, I learned some pretty wild stuff.
Oh, really? Like what?
Well, did you know there's actually a drug that can reverse paralysis from muscle relaxants? It's like a real-life antidote.
Wow. Yeah. It's pretty amazing how that works.
Right. And get this, anticholinergics can actually cause a temporary fever.
Yeah, especially in kids. We call it atropine fever sometimes.
Huh, didn't know that. And some of these drugs, they can even get past the blood-brain barrier.
Oh, yeah. They can have some pretty interesting effects on the central nervous system.
It's like mind-blowing. So yeah, we're going to unpack all of that and more today. And to help us navigate this, I've got an expert in anesthesiology with me.
Happy to be here.
All right, so first things first, cholinergic pharmacology. What exactly are we talking about here?
Well, it all starts with acetylcholine, or AC.
Okay, HF.
It's a neurotransmitter that's involved in a ton of vital functions. Think muscle contractions, the autonomic nervous system, even the central nervous system.
It's like heart rate, breathing, memory.
Exactly. It's a pretty big deal.
Wow, so HE does all that by binding to receptors, right?
You got it.
Are there different types of receptors?
There are, yeah. The main two are muscarinic and nicotinic receptors.
Okay, muscarinic and nicotinic. And those are where the AG key docks.
Yeah, you can think of them like that, like specialized docking stations.
Interesting. And each one triggers different actions, I'm guessing.
Right, exactly. That's how big key can have so many different effects in the body.
Okay, that's cool. So where are these receptors and what do they actually do?
All right, so muscarinic receptors, they're mainly found in the organs controlled by the parasympathetic nervous system.
Oh, the rest and digest system.
Yeah, that's the one.
Okay.
So we're talking smooth muscles, heart, glands, things like that.
And when AKI binds to those receptors, what happens?
Well, it slows down your heart rate, stimulates those glands to secrete, and makes smooth muscles contract.
So, if muscarinic receptors are the rest and digest crew, are nicotinic receptors more? Fight or flight?
You got it.
Makes sense. So where do we find those?
Nicotinic receptors are in a few key places. Autonomic ganglia, which are like relay stations in the nervous system, the adrenal medulla, where adrenaline is produced, and importantly, at the neuromuscular junction. That's where nerves communicate with muscles to make them contract.
Right, right. It's amazing how one neurotransmitter can have such a wide range of effects. Just depends on which receptor it activates.
Yeah, it is pretty remarkable, and that's actually where the concept of selective blockade comes in.
Selective blockade. What's that?
Basically, we can design drugs that target specific receptor types.
Oh, I see.
So we can fine-tune our interventions and get more precise effects.
That makes a lot of sense.
Sure.
Okay, so we've covered the basics of AG and its receptors. Now let's talk about those paralysis-reversing drugs, the cholinesterase inhibitors.
All right, let's do it.
Remind me, how do they actually work?
Okay, picture the neuromuscular junction. That's where the nerve meets the muscle.
Got it.
When a nerve impulse arrives, it releases acetylcholine.
Oh, right.
Yeah. And that HE binds to nicotinic receptors on the muscle fiber, causing it to contract.
So far, so good. But then we need the muscle to relax again, right?
Exactly. And that's where acetylcholinesterase comes in.
Acetylcholinesterase. Catchy name.
We usually just call them that breaks down AC, basically ending the signal to contract.
Like a cleanup crew.
Exactly, making sure the muscle can relax again.
Gotcha. So how do cholinesterase inhibitors fit into all this?
Okay, so imagine we give a drug that causes paralysis,
Yeah.
specifically a non-depolarizing neuromuscular blocking agent, or NMBA.
NMBA, okay.
They compete with AC for those nicotinic receptor spots, but they don't actually activate the muscle.
So the muscle's just stuck in a relaxed state, paralyzed.
Exactly, and that's where our cholinesterase inhibitors come in.
They're the heroes, but how do they reverse the paralysis?
They inhibit AT.
Inhibit AKI, so they stop the breakdown of AKI.
Right. That allows AC to build up in the space between the nerve and the muscle.
Okay.
And with more ATK around, it can outcompete the NMBA for those receptor spots.
So it can bind and make the muscle contract again.
Exactly. Neuromuscular transmission is restored.
So it's like they're slowing down the cleanup crew so AC has more time to do its thing.
That's a great way to put it. Now, there are two main types of ACE inhibition: reversible and irreversible.
Oh, okay.
Luckily, most of the drugs we use clinically cause reversible inhibition.
So the effect is temporary.
Exactly. We want to be able to control the paralysis, right?
Right, of course. What about irreversible inhibition?
That's usually caused by things like organophosphates.
Like pesticides.
Yeah, pesticides, nerve agents, things like that. They form a permanent bond with ACE, leading to a dangerous buildup of ACE.
Yikes. Okay, so reversible good, irreversible bad. Are there any situations where using cholinesterase inhibitors, even the reversible ones, could be risky?
That's a great question. Yeah, there are certain conditions where we need to be extra careful.
Like what?
Well, in patients with asthma, for example, cholinesterase inhibitors can worsen bronchospasm.
Oh, right. Because of their effects on the parasympathetic system.
Exactly. And in patients with heart conditions like bradycardia, they can slow down the heart rate even further.
So it's not a one-size-fits-all kind of thing.
Nope. We always have to consider the individual patient and weigh the risks and benefits.
Okay, that makes sense. So what are some of the most common cholinesterase inhibitors we use in anesthesia?
Well, some names you'll definitely come across are neostigmine, pyridostigmine, edrophonium, and physostigmine.
All right, 4 to remember. So when would we choose one over another? What are their ideal use cases?
That's a great question, and it depends on a few things, like how quickly we need the reversal to happen, how long we need the effects to last, and of course, the patient's overall medical condition.
Okay, so there's a lot to consider. Can we break down each of these cholinesterase inhibitors in more detail? Awesome. Let's start with neostigmine.
Okay, neostigmine, it's kind of the classic one.
All right, good place to start.
Yeah, neostigmine's a good one to know inside and out. It's like our go-to for a lot of situations.
Right.
So picture this, surgery's over, we need to get our patient breathing on their own again. That's when neostigmine comes in.
Makes sense.
Yeah.
So we know it inhibits acetylcholinesterase, but what else is important to remember about it?
A few things. First, onset. It takes about 5 minutes to really start working, and it reaches peak effect around 10 minutes after we give it.
So it's not instant, but it's pretty quick.
Exactly. And then the effects last for about an hour, which gives the patient plenty of time to recover from the neuromuscular blockade.
Got it. Quick onset, decent duration of action. What about dosage? Is there a standard range we aim for?
Yeah, usually around 0.04 to 0.08 milligrams per kilogram of body weight. But the max dose for adults is 5 milligrams.
No.
And of course, we always give it with an anticholinergic.
Right, to counteract those muscarinic side effects. Got to keep things balanced.
Exactly.
Right. Usually we use glycopyrrolate for that, right?
Yep, glycopyrrolate's a good choice. A good rule of thumb is 0.2 milligrams of glycopyrrolate for every 1 milligram of neostigmine.
Okay, easy to remember. So that helps prevent things like bradycardia and excessive secretions.
Exactly.
This is really helpful. Are there any other, tips or tricks with neostigmine?
Well, this is interesting.
Okay, tell me.
Even though we often use neostigmine to reverse neuromuscular blockade, it's not the best choice for pregnant patients.
Really? Why is that?
It can cross the placenta and cause fetal bradycardia.
Oh, wow.
So in those cases, atropine might be a safer option as the anticholinergic.
Interesting. So atropine doesn't have the same effect on the fetal heart rate.
Right. It doesn't seem to.
Man, there's so much to think about when choosing the right drug.
There really is.
And, this whole time I've been thinking neostigmine is only used for reversing neuromuscular blockade. But it's not, is it?
Nope. It's got other uses too. We also use it to treat myasthenia gravis, which is an autoimmune disorder that affects muscle function.
Oh, right. I remember learning about that.
And it can also help with things like urinary bladder, atony, and paralytic ileus.
So it's a real multitasker. Okay, I think I've got a pretty good handle on neostigmine now. What's next?
Let's move on to pyridostigmine, another common one.
All right, pyridostigmine. Bring it on.
The key difference here compared to neostigmine is that it's less potent.
Less potent? Oh.
Yeah, about 20% as potent as neostigmine. So we need a higher dose to get the same effect.
Okay, so if we need a really rapid reversal, neostigmine might be the better choice.
Yeah, probably. Especially in those time-sensitive situations.
Got it. So pyridostigmine, less potent. What's the typical dose then?
We usually give up to 0.25 milligrams per kilogram of body weight.
All right. And how long does it take to kick in?
If neostigmine takes about 5 minutes to start working.
Pyridostigmine's probably a little slower, right?
Yeah, you got it. It takes about 10 to 15 minutes to really kick in. But here's the trade-off.
Okay.
Its duration of action is actually longer than neostigmine.
Really? How much longer?
Often it exceeds 2 hours.
Interesting. So, same side effects.
Got it. What else is there?
Next up, edrophonium.
Edrophonium, okay.
This one's the speedster of the group.
Oh, How fast are we talking?
It kicks in within 1 to 2 minutes.
Wow, that is fast. But I'm guessing there's a trade-off.
There is, yeah. Shorter duration of action, usually less than an hour.
So it's like a quick fix. When would we use edrophonium then?
It's great for reversing mild neuromuscular blockade.
Okay, I see. Just a little boost to get the muscles working again.
Exactly, when we
Okay.
don't need a super long-lasting effect. Makes sense. What about the dose for edrophonium?
Typically around 0.5 to 1 milligram per kilogram of body weight.
Okay.
And because it acts so quickly, we usually pair it with atropine.
Right, atropine's also fast-acting. They're like the power couple.
Exactly.
What's the typical atropine dose when we're using it with edrophonium?
Good rule of thumb is 0.014 milligrams of atropine for every 1 milligram of edrophonium.
All right, got it. So we've covered neostigmine, pyridostigmine, edrophonium. One more left, right.
Yeah, the last one's physostigmine.
Physostigmine. Okay, what's special about this one?
Physostigmine is unique because it can cross the blood-brain barrier.
Oh, right, right. We talked about it earlier as the antidote to cholinergic toxicity. But it has other uses too, right?
It does, yeah. Because it can get into the central nervous system, it's actually really effective for treating shivering.
Oh, interesting. So it helps with that shivering patients sometimes get after surgery.
Exactly. It's a pretty common side effect of anesthesia, and it can be really uncomfortable. So physostigmine can help with that.
That makes sense. But we don't typically use it for reversing neuromuscular blockade, do we?
Not usually, no, because of that whole blood-brain barrier thing.
Right. It can cause those central nervous system side effects.
Exactly. And we usually want to avoid that when we're just trying to reverse muscle relaxation.
Okay, I see. So physostigmine brain penetrating, good for shivering, not ideal for routine neuromuscular blockade reversal.
Yeah, that's a good way to put it. Okay, so we've covered the cholinesterase inhibitors. What do you say we switch gears and talk about the anticholinergics?
Oh yeah, let's do it.
Those are the drugs that help us balance things out, remember? Keep those muscarinic side effects in check.
Right. Like a seesaw. Keep everything level. I'm ready to talk of dry mouths, dilated pupils, all that fun stuff.
All right, let's dive in. So, anticholinergics, they're all about restoring balance, right? Think back to those cholinesterase inhibitors and how they can sometimes cause problems in the parasympathetic nervous system.
Yeah, they can really get things going sometimes. Bradycardia, increased secretions. It's like they open the floodgates.
Exactly. And that's when we need anticholinergics to step in and calm things down a bit, block those muscarinic receptors.
Right, so AD can't go overboard.
Exactly. It's like putting a gentle brake on that whole rest and digest system.
Makes sense. So we talked about all the different things AD can do depending on which organ system we're looking at. Do anticholinergics have their own unique effects on those systems too?
Oh, absolutely. They definitely have their own ways of influencing things.
Okay, I'm ready for the rundown.
All right, let's start with the heart, cardiovascular system.
Okay, the heart. What happens when we give anticholinergics?
Well, they block those M2 receptors in the sinoatrial node, which is like the heart's natural pacemaker.
Right, right. And that leads to tachycardia.
You got it.
Yeah.
They speed up the heart rate.
Because they're blocking that parasympathetic influence, right?
Exactly. It's like they're giving the heart a little nudge saying, hey, pick up the pace a bit.
So it's the opposite of what cholinesterase inhibitors can do.
Right. Sometimes those inhibitors can slow the heart down too much.
Makes sense. So anticholinergics are really useful for treating bradycardia.
They are, yeah.
Yeah.
Especially when it's caused by those exaggerated vagal reflexes.
Oh, right, right. Those sudden drops in heart rate during surgery?
Yeah, those can be traumatic. Anticholinergics help us smooth things out and keep the heart rate in a safe range.
Okay, that makes sense. So we've covered the heart. What about the lungs? The respiratory system?
How do you think anticholinergics affect the airways?
Let's see. I remember they work in two main ways. First, they reduce glandular secretions, which I'm sure the surgeons appreciate, especially during intubation.
Oh, yeah, definitely.
And second, they relax the bronchial smooth muscle, which causes bronchodilation.
You nailed it. They open up those airways and make breathing easier, which is especially helpful for patients with COPD or asthma.
Right, right. It's amazing how these drugs can have such opposite effects depending on which receptors they're targeting.
It really is. It shows you how complex the human body is and how much we can influence it with pharmacology.
Okay, so we've done the heart and lungs. What about the GI tract?
What happens down there when we introduce anticholinergics?
Things tend to slow down a bit, don't they?
They do, yeah.
Reduce salivary and gastric secretions, which is good for preventing aspiration during surgery, but they also delay gastric emptying. So food takes longer to move through the stomach.
You're exactly right. It's like they're telling the stomach, hey, take a break. No need to rush things here.
And I think they could also relax the lower esophageal sphincter, right? Which could increase the risk of acid reflux, especially in patients who already have heartburn.
That's a good point. It's always a balance, considering the benefits and the potential risks.
Right. Okay, so we've done heart, lungs, stomach. What's next?
What about the eyes? How do you think anticholinergics affect those?
Oh, I know this one. They block the M3 receptors in the iris sphincter muscle, causing the pupils to dilate. Mydriasis, right?
That's it. Wide eyes.
And they can also cause cycloplegia, which is paralysis of the ciliary muscle. So the eye can't focus on near objects as well.
Right. It's like temporarily disabling the eye's autofocus system.
Exactly. Now, I know these effects can be useful in ophthalmology, but are they a big deal when we're using anticholinergics systemically during anesthesia?
Not usually, no. It's good to be aware of them, but they usually don't cause any major problems.
Okay, good. So beyond those specific organ systems, are there any other general effects of anticholinergics that we should know about?
Yeah, there are a couple more things to keep in mind.
Okay, what are they?
They can inhibit bladder detrusor muscle contraction, which can lead to urinary retention, especially in men with enlarged prostates.
Oh, right.
And they also inhibit sweat gland activity, so less sweating, which can cause the body temperature to rise a bit.
We call that atropine fever.
Yep, atropine fever.
And some anticholinergics can even cross the blood-brain barrier, right?
They can, yeah. Atropine and scopolamine especially can have some interesting central nervous system effects.
What kind of effects?
It can range from sedation and amnesia to, at higher doses, delirium.
Whoa, so they can really mess with your head.
They can, yeah.
Yeah.
But remember, glycopyrrolate doesn't cross that barrier.
Right. So it's often a better choice if we want to avoid those central effects.
Exactly. Especially in older patients, we try to avoid those.
Okay, makes sense. It's fascinating how each of these drugs has its own little quirks.
It really is. Okay, so we've covered the general effects of anticholinergics. Now let's talk about the specific drugs we use in anesthesia.
Okay, let's do it.
We've got our three musketeers: atropine, scopolamine, and glycopyrrolate.
Right. Each with its own strengths and weaknesses.
Exactly. So let's start with atropine. What are some key things you remember about this one?
Okay, let's see. Atropine. It's a potent drug, has a strong effect on both the heart and the bronchi. It's really effective for treating bradyarrhythmias, and it's a good bronchodilator too. We usually give around 0.01 to 0.02 milligrams per kilogram for premedication, but we can go up to 2 milligrams IV if we're dealing with a serious bradycardia.
Perfect. You remembered all the key points. And don't forget about that paradoxical effect at very low doses.
Oh, right. It can actually slow down the heart rate before it speeds it up.
Exactly. Pharmacology always keeps us on our toes.
It does. Okay, so atropine's potent, versatile,
Mhm.
but are there any situations where we might want to be cautious about using it?
We definitely need to be careful in patients with coronary artery disease.
Oh, right, because the tachycardia can increase the heart's demand for oxygen while decreasing the supply.
Exactly. And while atropine's CNS effects are usually pretty minimal at normal doses, larger doses can cause excitement or delirium, especially in older patients.
Got it. So careful dosing, always.
Always.
Okay, what about scopolamine? This one always seems a bit more mysterious, I guess.
Scopolamine is definitely a bit of a wild card. It has both central and peripheral effects, which makes it a little more complex to manage.
Yeah, I can see that. What are some of its key characteristics? I know it's a more potent antisialagogue than atropine.
Yeah.
It really dries up those secretions. And it also has stronger central nervous system effects, causing sedation and amnesia. We use it for motion sickness prevention and sometimes for premedication before anesthesia.
You're on a roll. But yeah, those central effects can be tricky. The sedation and amnesia can be helpful, but they can also interfere with waking up from short procedures.
Right.
And at higher doses, it can cause restlessness, dizziness, even delirium, especially in older patients.
So definitely a drug that needs careful dosing and close monitoring.
For sure.
And what about those ocular effects? Scopolamine can dilate the pupils, right?
It can, yeah. And it
Yeah.
can cause difficulty focusing. So we have to be extra careful in patients with narrow angle glaucoma.
All right. We don't want to trigger an acute attack. That would be bad.
Definitely bad.
Okay, so scopolamine potent, a little unpredictable, and needs extra consideration in certain patients. What about our last anticholinergic glycopyrrolate? What makes it different?
Glycopyrrolate. This is the one that's friendly to the brain.
Right. It doesn't cross the blood-brain barrier, so no sedation, no amnesia, no delirium. It's still a good antisialagogue, though.
Yeah.
And it actually lasts longer than atropine, doesn't it?
It does, yeah. Usually 2 to 4 hours after an IV dose.
Okay, so longer duration of action. Anything else that's unique about glycopyrrolate?
Well, this is interesting. It usually increases heart rate after an IV dose, but not after an IM dose.
The body is weird.
It is.
Yeah.
But yeah, so glycopyrrolate is a good choice when we need a long-lasting anticholinergic effect without the risk of those CNS side effects.
It's a good option for older patients or anyone where we're worried about delirium.
Exactly. All right, one last thing before we wrap things up. Anticholinergic toxicity.
Oh, right. Important to know about that.
Definitely. So imagine a patient who's been given too much of an anticholinergic. What kinds of signs and symptoms would you expect to see?
Okay, well, it would basically be a whole body meltdown, right? Centrally, we might see anything from unconsciousness to hallucinations, agitation, delirium.
Cool.
And then peripherally, dry mouth, tachycardia, flushed skin, elevated temperature, blurred vision.
You got it. It's like the body's fight or flight response gone haywire.
And what's our go-to treatment for all of that?
Physostigmine, our friend that can both inhibit acetylcholinesterase and reverse those central anticholinergic effects.
Right. We usually give it IV, right?
They do, yeah. Starting with a dose of 0.01 to 0.03 milligrams per kilogram. But it's important to remember that supportive care is just as important as the antidote.
Oh, yeah, of course. Cooling measures, IV fluids, monitoring those vital signs.
Exactly. It's a team effort.
It is.
Okay, before we finish up, I want to leave you with something to think about.
Okay, hit me with it.
We talked a lot about how important it is to balance those cholinesterase inhibitors and anticholinergics to make sure patients wake up smoothly and safely from anesthesia. But there's always the potential for residual paralysis, and every patient is different. So how can anesthesiologists best personalize their approach to managing neuromuscular blockade and reversal? It's a tricky question.
It is. It really shows you that there's a lot more to learn than just memorizing drug names and dosages. We have to think about each patient individually.
Exactly. That's what makes anesthesiology so challenging and so rewarding.
It does. Well, this has been a fantastic deep dive. Thanks for walking me through all of this.
My pleasure. And to all of our listeners out there, thanks for joining us. We'll see you next time for another deep dive into the fascinating world of, well, whatever we decide to explore next.
Until then, stay curious.